Good morning, everyone. Welcome to our Boardroom Bites at 9 session for today. Our speaker for this morning is Dr. Ntuthuko Bhengu. He is, he has a wealth of experience in the healthcare industry and in terms of corporate SA. And today he's talking about COVID-19 and corporate SA. What have we learned specifically from a healthcare industry perspective? So Dr. Bhengu, I'm going to hand over to you, and I will see all of you again during the Q&A.
Thank you very much, Ms. Vandaya. Good morning, colleagues. Welcome to today's talk. The agenda, I will really just start off briefly with a case study that I think is relevant to carry the theme of the presentation through. We'll have a quick run over the private sector dynamics, focusing mainly in 2014. That was a landmark year because one of the regulators, based on its initial sort of research, commissioned the health market inquiry. And then we look 5 years later, where are we? We'll also look at the South African household situation. On the one side, to what extent are South Africans very much likely to afford private healthcare, but also are there signs that given a chance they would like to access this type of care. We'll go global again in looking at 9 trends that will shape work. This is one of the latest work published by Gartner and published this year. And then, of course, we come back, what have we learned? I believe that COVID has just served to highlight the weaknesses that have always been there. But it's very useful when one tries to explain that we cannot keep pretending like healthcare doesn't matter. And of course, part of that is really just what corporate South Africa can do to help with the necessary transformation. The case study I'm referring to is a very old one, in 1984 to be exact, and I've chosen this article from the New York Times. At the time, the CEO of Chrysler, Lee Iacocca, was quoted widely saying, when we tried to analyze our costs, we found Chrysler was dying of healthcare. The article goes on to say, 2 years ago, when Chrysler was on the ropes, the union agreed to give up some wages, cost of living raises, vacations, and other benefits, but the health plan went untouched. Health benefits, Mr. Fraser said, are sacred ground. The problem is the system. What have you, Mr. Iacocca said, is a huge vested interest. The doctors and hospitals that says this is a profession. This isn't a supplier. And you keep your cotton picking hands off. If I want to buy steel, I can go to the lowest seller. But in health, the buyer-seller relationship doesn't exist. Yet, in fact, Blue Cross Blue Shield is my biggest supplier. Now, for those who may not know, Blue Cross Blue Shield is an almost 100-year-old health insurer that covers about 1/3 of Americans today. This case study is of interest to me precisely because it's old. In 37 years, the question has to be asked, has there been a remarkable change in the weaknesses of health systems, especially private health systems? The United States health system is closest to the model we have for our private health system, and actually the means we use to manage cost of care are largely the same. But what this also tells us is that you have the largest company at the time that got a very clear message from employees that you do not touch our health benefits. And also you have the CEO of the same large company who says, I cannot see how this industry works. I'm forced to stay out. So that is largely the theme of what we will be going through. Yeah, coming back home, the Competition Commission established the Health Market Inquiry based on what it deemed were features of the sector that prevented, distorted, or restricted competition. And structurally, it was largely the consolidation in markets that was evident. Hospital groups, 3 hospital groups owned 80% share of beds. 3 administrators managed 78% of scheme beneficiaries, and 3 medical schemes covered more than 55% of all beneficiaries. Expenditure over a 10-year period, there had been about a 40% increase in hospital expenditure and about 55% of medical specialists. And also, looking at the household experience, healthcare prices exceeded headline inflation by an average of 4.3 percentage points. And on the regulatory front, of course, is the issue of this an industry defined by agents and information asymmetry. But what we need to always bear the back of our minds is that healthcare is a human right, and as such, it's protected in our Constitution under Section 27. I must end off by saying, well, these research findings at the beginning were by and large confirmed by the Health Market Inquiry, and obviously it went beyond just this. But it also wouldn't be fair to omit that the industry players participated fully and willingly shared the weaknesses of the industry. The problem now is that none of the recommendations have been implemented. So where are we now? I'm citing here a series of slides from the Council for Medical Schemes that gives us a high-level view of the critical issues. You are looking at a slide that shows the number of medical schemes. There are about 78, 20 of which are open schemes. The balance are restricted schemes, which are open to members of a particular company or members of an industry. The very clear trend here is that of consolidation, where you have over 10 years a reduction in the number of schemes that are in the market. This one basically gives us a view of the number of beneficiaries. By that we mean primary members and their dependents, which is 9 million by last count. But what you also see here is that there was a period of growth between 2005 and followed by a plateau. This is attributed to the entry of the government employees medical scheme, which was very well structured in terms of subsidies. But if you look in, you can see that on the open schemes, there really hasn't been growth. It's been stagnant. And it has to be said that, of course, this is just a portion of people who are employed, those who are covered by the scheme. This slide shows you the graph of gross premiums that are paid per beneficiary per month. And right now, right towards the end, you can see it's about 2,000 Rand on average for one member to be on a medical scheme. And this one, really the last of the series, shows us here. This is a 200 billion Rand industry based on premiums paid. And 37% of that goes for hospital care. And 25% is all medical specialists. Medicines dispensed, about 15%. Supplementary and allied professionals, 7.6%, and 5.5% is for general practitioners, largely, but this is for primary care. Now, on the issue of affordability, here you have about 55% of South African population live in households where the breadwinner earns less than about 6,000 Rand per month. And you must go back to the slide I just played, which says you are looking at about, on average, 2,000 Rand per member. That's what it would cost to be a member of a scheme. So quite clearly, you can see that on the affordability front, we're already starting to have problems there. And approximately 15% of South Africans belong to medical schemes, but twice that number make use of primary care in the private sector, supported by General Household Survey. And then 46% of South African households spent money of private care in the past 12 months, and about 41% responded to use a private provider at their last healthcare visit. So the summary of the industry, as we've just looked at it, there are three main takeaway points. One, it's a sector that has a history of features that are suggestive of market failures everywhere, and this is really not just suggestive, it was found to be so through the inquiry. Private sector is unaffordable to most employed people. I'm not just talking about people, I'm talking about employed people. The demand for private sector exists, as we can see that, especially on the primary care side, whenever there is a need for healthcare, even those who are not employed, who can barely afford, they still go for private sector. I suppose the corollary is that if you're not on medical aid, you essentially can't afford hospital services. So, as I said, COVID has brought into light a lot of issues that those in the industry have always known, but now they are out in the open and more visible. And I make a point here that health is too important to be left only to the health sector. And this is not me suggesting that the industry is not capable of taking care of its industry, but it's exactly what we're seeing on COVID. Everybody has been involved in getting COVID under control. There are many ways that employers can assist in dealing with transformation issues in this industry. Government engagement, policy implementation. The health market inquiry is a perfect example where a lot of work has been done, but there is no implementation now. Which other industry really doesn't have a pricing structure? I do not think you can think of any. To a lot of, if not most of us, we only find out after consuming care how much it will cost. Why is this acceptable? Why is this acceptable to a body as influential and full of information as corporates are? We know of decades of above inflation increases, but would we see or basically observe just no issues? Should that, as we know, if we want to compare, for example, with electricity, we know exactly how industry responds every time electricity costs go up above inflation. Now, I will come back to this point, but the point is also to say the response of corporates to COVID has been nothing but impressive. You look at the Solidarity Fund, B4SA, Black Business Council, the Board of Health Funders, Compensation Funders, everyone is really putting their shoulder to the wheel to make this work. But other pandemics are just as important, pandemics in inverted commas, and these are non-communicable diseases. Your hypertension, your diabetes. And the point here is that corporate South Africa has shown what it can do, and one hopes you will not step back from what we now know you can do in saving lives. The risk for corporate South Africa is that if once COVID has come under control, you step back, questions will be asked that did you jump because John, the security guard this time, when he coughed, he posed a risk to the CEO. But he can go and deal with his hypertension at home and nobody cares. So this is going to be an important benchmark, and corporate South Africa must be held to the same standards in observing how we respond to healthcare in particular. Now, we also have learned that employees do value access to quality care. I've used an example here of Chrysler and Amazon in today's times also dealing differently with what is a healthcare problem. So it hasn't gone away. Now, locally, what is also relevant, which is a similar indicator, is that there has been negligible medical scheme lapse rate during COVID. Just think about it. At the time when people were under tremendous financial stress, the one thing they held on to was their access to the private sector. This has been confirmed with the Board of Health Fund, as I spoke to one of the executives, and really just confirming that their revenues largely are based on scheme membership, and there really hasn't been a fall. And I think Discovery has also been in the media explaining this and other medical schemes. So there can be no doubt that this is a valued benefit by members. So corporate has to step up. And the fourth point here is that healthcare is a global priority in future, and signs are there and commitments are there. And corporates have a bigger role to play than ever. And I refer to 9 trends that will shape work in 2021 and beyond. This is a result of a study commissioned by Gartner and published in the Harvard Business Review in January this year. Employers will shift from managing employee experience to managing the life experience of their employees. What the study found is that with COVID, like never before, employers have been able to see more of the lives of their employees outside of work. And that has touched on a nerve that says clearly corporate has got to be more responsible. In terms of numbers, those who belong to employers that are supportive have reported a 23% increase in their mental health, 70% increase in improvement in their physical health. And on the other hand, there has been a difference about 21% in high performance for those companies that support their employers compared to organizations that provide absolutely no support during this time. The other prediction is that more companies will adopt stances on current social and political debates. The gender wage gap will continue to increase as employees return to the office. This one was particularly interesting because they say here that managers basically feel that employees are more effective when they are at work. But more detailed studies show that productivity has been much better with people who are working from home. Now, this obviously is aligned to the fact that by and large, it's males who are actually in management or leadership position. So it is expected that they will continue to tailor their rewards in this faulty sort of basis, because it seems that men are more likely to be in the office in this work from home environment. There will be new regulations that will limit employee monitoring. And flexibility will shift from location to time, meaning flexibility doesn't necessarily, it's not so much about whether you're at work or home so much, but it's about time. Leading companies will make bulk purchases of COVID vaccine for employees and will be sued over COVID vaccine requirements. Mental health support is the new normal. There are expectations that there will be 45% budget increases for mental well-being programs. 68% of organizations had already introduced at least one new wellness benefit prior to COVID. This is expected to expand in 2021 and beyond. Employers will look to rent talent to fill skills gap, and states will compete to attract individual talent rather than trying to get companies to relocate. This is clearly states as in the United States. But the key point of this is that of these 9 trends, 3 are certainly front and center healthcare trends. And if one looks at the second one, more companies will adopt stances on current societal and political debates. A lot of other health issues will find themselves there. We are already engaged now as we speak in debates about vaccine apartheid. It's going to be an issue again, whether if you're vaccinated, does it mean you have access to more amenities, to more work opportunities, to more travel opportunities. So by all accounts, it is very clear that healthcare, quite rightly, is getting the attention that it deserves in making sure that quality care must be delivered and be accessible to as many people as possible cost effectively. Now, what can corporate South Africa do? There is a lot. I've obviously just limited to a few, starting with the medical scheme industry, because this is the industry where most of you, for most of you, is the contact point with the health sector. My point is that just putting in a medical scheme program is not enough. The very simple reason is just simply that you're not even covering all of your employees. You're covering fewer than all employees in corporate SA. If one looks at the figures from States SA and you do your deductions, looking at the Council of Medical Schemes, it's quite clear that at best, you're not even talking about half. We've got 9 million employed people, but of course, the sort of beneficiaries of medical schemes, but the ratio of the employed to the beneficiaries is much less. So there is no doubt that the figures show that it can't be enough to just say you have a medical scheme program in place. You're not touching all of the people that you should. It actually is worse because those that are outside of this arrangement are those that are more vulnerable. And leaving the numbers aside, it is my view that there is not sufficient engagement even when there is a medical scheme in place. Premium increases, as I said, except for the last year COVID, are forever 3 percentage points above inflation, and it seems to be just accepted. And corporate South Africa pays, but does not ask for outcomes. The coverage is not growing. Employers, when employees have to pay more and more out of pocket, they just simply fall out of the system, and I do not see enough of a response in terms of engaging and asking how did we get here. And the reason I'm asking this is not so much by wanting to place the industry on the spot here, but it's recognition that the industry will only improve and absorb more people if it is subjected to as much scrutiny to explain not only its consumption of resources, but also to indicate how these resources are actually used. And I have no doubt that once that discussion starts happening, the entire system will improve, because now the medical scheme will have to explain itself, and that will trickle down to the hospitals, to the practitioners that are providing services, and it will actually come back to those who are employed, because ultimately healthcare starts with the person. So it does not help anybody to have a relationship where it's really just about transferring funds for the premiums, and then we'll actually see at the end of the year and see what happens. Industry needs all hands on deck, and that includes it being held to account. Competition is a critical issue. There are people who believe that healthcare needs to operate outside of Competition Act, but it's just not true. It doesn't make sense. We do know that where there is less competition, prices are likely to be higher than they should be, and the quality will be less than it can be. And in relation to medical schemes, employers should really consider not just saying we have 1 or 2 schemes for you to choose from. The more schemes you make available and allow your employees to choose from, you're giving them a better chance of finding what they can afford. But also, from a competition perspective, it's just the right thing to do, because then you're opening up for competition in terms of pricing, in terms of the type of service quality. And still on medical schemes, you need to invest in expert advice. You should not just choose your service provider, medical scheme provider, on the basis of what it apparently costs on the medical scheme premium. There are too many options. It's very complex. And to show you this, I have chosen to use this model from Insight Actuaries, very well respected in the industry. And the purpose is just to show you just how complex this is. And if you do not get the right kind of advice, you are likely to not make choices that are actually good for the company and the employees. This slide shows you, well, the consultants quantified the value of each medical scheme option in the market, modeling the benefits against costs. You can see how wide the range of options are. So it explains what I mean when I say it's quite complex. The options that usually face the employer is either there's going to be a restricted scheme or there's going to be an open scheme, and maybe a split risk where there will be a few open schemes. And this is apparently a trend now, a growing trend, because of cost to company provisions and also individuals definitely wanting more choice. The point is that it's not a simple industry. We said there are 78 medical schemes, especially on the open scheme environment. We are looking about 4 or 5 options on average. It is not straightforward. So what can corporate South Africa do? I think the slide is, it follows. Remember that the number one point was about what you can do within the medical scheme environment. The next point is for corporate South Africa to involve itself in current debates about low-cost benefit options. This is current, it's been going for many years, but again, it's about trying to make room for those who are employed, but not insured. There are many points that are up for debate here, including who the regulator should be, the Council for Medical Schemes or Financial Services Authority. Should we be looking at a standard benefit design or a continuum of options? What is essential though, what is obvious is that LCBOs are necessary, because if you look at the medical scheme industry, the point that makes the floor very high is, among others, is really just the need to cater for PMBs, prescribed minimum benefits. And this is not a criticism, this is exactly the point of what this is about. Just for indication of what the range is from LCBO, I think LCBOs, you're looking at Really, the bare bones around 150 to about 700 rand per life. But this is dynamic because it's discussion that's happening. And I'm saying corporate South Africa mustn't just stand back and not participate. And you must learn to engage service providers directly. Service providers being professionals in establishments. Medical scheme industry does this very well for its members. But who does that for the employees who do not have cover? It's very much important and helpful that as a member of a medical scheme, the manager has got access to incentives that drive health, go to gym. But who provides incentives for those who are not insured? It doesn't mean that they wouldn't benefit from that. That's one example of a gap that is glaring and drives the inequities further apart. There are examples here, and of course, large employers could do that directly with their service providers, either by industry or by region. The mining industry itself owns facilities and employs practitioners that's quite well known and runs probably the largest health system outside of government. But also, there is an example in the Eastern Cape where car makers entered into relationships with providers to make sure that their employees are covered. It's a debate that needs to happen. Otherwise, we're leaving too many people outside of healthcare. Now, in terms of final takeaway points, when Lee Iacocca said, but Blue Cross Blue Shield is my largest service provider, the only reason or probable reason, in my view, why South Africa, corporate South Africa doesn't say this, it's simply because it does have a way out. While in the US, there is no government service except if you are old or are disabled, Medicare and Medicaid. In South Africa, there is the option of just not worrying who's covered, who's not. Or maybe the public sector as a safety net. But is it a safety net? The reality is that we don't know what the outcomes are. And in my head, it's questionable. If you see how many people who barely afford still will find the money to try and look for private healthcare, there is an obligation for good corporate citizens to work to find the solution here. And if we believe that our public sector is failing, it's not a good enough reason not to try. I had made example on the basis of lobbying, but it doesn't end there. It's about being actively involved in making sure this. Now, part of the reason I say this is that it's maybe corporate South Africa just doesn't see human health as valid inputs. The fact that the ROI is not so easily quantifiable is another reason that you're not promoting this. But how can we be happy with that? We talk about human lives. We have said that medical aid premium contributions aren't enough, and there's just no due diligence in terms of procuring. It's the easiest, it's the quickest. You have two to choose from. And I do hope that going forward, you'll realize that there's a lot more corporate South Africa can do. And if what I have said still does not move corporate South Africa to take care of all its employees' healthcare needs, maybe the economic fallout of COVID will help change approach ahead of the next pandemic. We do know all projections say it will come. So do we sit and say we've solved COVID, now we're going back to our way? I hope that's not what we do. But what COVID has done is that while we, from time to time, we do know about stock market collapses all over the world, but this is the first time you were stopped from doing your business. It's not a valuation issue. You just couldn't do business. So for the first time, you're not only sitting with an issue of taking care of your employees, but your customers' health matters too. So I do hope we take this into account. In any way, the reminder is that there obviously is an expanded view of what dealing with healthcare costs is about. A winning corporate strategy is no longer just about reducing healthcare costs. Health Affairs have got an article that shows that you're talking about potential benefits of investing in wellness. Is not just about reducing healthcare costs, it's about improving worker productivity and worker engagement and improving in organizational performance. So there is very clear expectation that going forward, those who incorporate a healthcare strategy in their corporate strategy will definitely get a competitive advantage. And the last point here is that do support health sector innovation and entrepreneurship. It's quite obvious if you are at the VC business, but not everybody is. But the enterprise development options, enterprise supplier development options. Now more than ever before, healthcare has certainly moved ahead regarding investments flowing into technology that improves healthcare. So it's no longer just what used to be defensive stocks. It's driving new innovations shown by budgets, by applications for IP, and some of the most successful partnerships are between experienced or large companies working with small emerging tech entrepreneurs. So my appeal is for you to work with us. And this is a whole presentation on its own, but I'll just leave it to you that these are companies that we know for every reason, for different reasons, different products, top-class customer engagement. They understand how to work the customer. And the thing is this, in 5 years, these will primarily be healthcare companies. And it's not unrelated to the point about supporting healthcare entrepreneurship. Amazon, what can you say? Whether you're looking at the pharmacy sort of product, the pharmaceutical business case that is obviously founded on what they are known for. Apple is all over our phones with healthcare issue. Google has got 3 companies now that are just healthcare companies. And Microsoft is obviously very strong in healthcare. The point I'm making is that there is a reason these companies that are highly successful in their primary markets have now focused on healthcare. And I'm asking that corporate South Africa does play its part, starting with looking after its employees. Thank you very much, Chair. That's the end of my presentation.
Thank you, Dr. Bhengu. So we're in the Q&A session now. I see there are a few questions in the Q&A box, but if you would like to ask a question live, you're more than welcome to raise your hand and I will enable your talk functionality. So let's start off with Jeremy wants to know, will the NHI take off and how will private medical aids be impacted by this should it happen?
Chair, do you prefer me to take the question as it comes?
Yes.
Or, okay, thank you. Yeah, look, just to say that my position is that the universal health coverage is necessary. The principles of social solidarity, the wealthy subsidizing the poor, the healthy subsidizing the sick, is a sound one, and I do not know anyone who's against that in principle. And as things stand, we expect that it's scheduled for 2026 to come online. My view is that I'm not sure if the timeline will be met. Of course, there has been responses to COVID and to try and actually learn from COVID to make sure that we're ready for this. My worry is that paragraph 33 of the National Health Insurance Bill is actually very vague, but suggests that we will not see the medical scheme survive as it is. I do hope that doesn't pan out. With all the faults of the medical scheme industry, it still is one of our best industries, and we need to follow. I worry that we miss the point the WHO makes all the time, that you start where you are with your financing. And we have a vibrant medical scheme industry that needs to be fixed, that's for sure. But that has to be our starting point. It's the technology, it's the schemes, it's the understanding of processes. Some companies have successfully exported this for a reason, because it means we do have something to teach the world. It's investments, it's skills, but I do not believe that you should say, if medical schemes survive, then people shouldn't pay for NHI. I think we should all contribute towards NHI, but then allow those who still want to buy their private care to do so. And the best way, in my view, is for me to decide 3 years after the NHI that, you know what, the NHI is so good, I'm just wasting my time, my money with my medical scheme, and let competition allow this. But more than that, I do not see what the disadvantage would be if many people who contribute towards the NHI don't use it. I see that as an important foundation that allows the NHI to establish itself. While it collects revenues, it doesn't, in the first instance, have the obligation to provide services. So that's a long way, but I thought it's important for me to give my view. But we have no reason to believe it won't start on the 2026. The risk is obviously that we still haven't an idea of the funding detail. And in South Africa, you will know that there's always the risk of litigation around the corner. I think those are speed humps that I think might just materialize between now and then. But it's not only that. There's a political angle that I hope will materialize. Some of the issues have to do with control of hospitals. I think this is not given the attention that is due, but I do suspect at some point control at that level for infrastructure and resources might materialize. And if it does, it only just extends the period between now and establishment of the NHI. Next question, please.
Thank you. Following that, and I'm not sure if you have answered this, being not my area of expertise, but SIPO wants to know your take on the industry and regulatory transition towards the NHI. It would be very interesting.
Yeah, one of the issues coming out of the health market inquiry, I'll keep referring to it because it was such an important intervention at the time that it happened. is that there is a whole lot of well thought out recommendations the industry contributed. And part of this is that there are short-term interventions that the government should be helping with now. And every single one of those recommendations, most of them, help build towards the NHI. So if government, while the NHI bill goes through the processes, there are easier wins, in my view, and things that we're talking about. It's really just getting the pricing process settled. It's about dealing with the licensing of hospitals where they become necessary. So the transition is also catered for in the bill. It's all down to implementation, but as far as I recall, that even some of those transitions, we have seen the establishment of benefits advisory committee. All of that is about transition. Of course, one has to be careful and not be too hard on government. COVID was not planned, and it actually has taken everybody's time. But the examples that I used are by and large lower hanging fruit. And it's not that they dissuade us from the route to NHI, but basically will benefit everybody in the long term.
Sorry, I'm on mute. And Nanda wants to know, should SARS not consider more tax incentives for employers driving better healthcare for their employees, which has broader benefits within and outside the organization?
Well, I do think that, well, the industry can use all the help it can get, and the industry, more than any other stakeholder group, responds to incentives. But I don't want to suggest I know enough. On a broad level, though, I do know that our economy is under pressure. And if anything, there is a tax benefit that has been there on the medical scheme that is among the first to go as part of funding the NHI, as it seems. Maybe it won't materialize that way, but certainly in principle, I don't know, it's hard to see, except that I support that all of us must contribute tax towards the NHI.
Taku, you've got your hand raised. If you can unmute.
Okay. Thank you very much, Dr. Bhengu. You mentioned the fact that those who work at home, there is improvement in productivity. Are you not saying it in relative terms? Because I believe it depends on the category of people, especially, I mean, the management, the leaders, usually the productivity will go high, but the lower cadre, you'll find that they run around. Thank you.
Thanks, Paco. Look, the context of that was really just me citing, as it was presented, 9 global trends that are expected, and this comes there. And we're still early. I haven't seen research that gives us very definitive answers here. So unfortunately, that's not my view. I was just saying, this is what somebody globally has found in terms of their studies. But there probably will be more going forward.
Thank you. So on to some similar questions. Sipokazi also says, is the 17% increase in physical health a result of reduced stress or an uptake of physical activities, better diets, or a combination of both?
Yeah, actually, this question comes exactly from the same study, but how it was presented This was more like reported, self-reported findings. 17% saying they're better physically, 23% say they're better mentally. Yeah.
A question from Molefi. What is the potential of telehealth in improving access to healthcare services?
No, certainly, I mean, practitioners before COVID were very much reluctant to use telehealth, but we've seen a spike in its use for the simple reason that, well, it protects everybody. If you think of the issues, you're able to manage the number of people that are in your waiting room as a practitioner, but also just the safety factor that if there is distance, you can do it via telehealth. Certainly, the uptake has been good, and there's so much investment going into this. But there are always limits, especially for first-time consultations. And because you really can't see, you certainly can't examine, I mean, remotely. But there's also the finance question, as that always comes up. And this one is about the reasonable consultation fees that are charged for virtual consultations. That is all in the picture as to what is fair and what is reasonable. Just because I'm consulting virtually, some will say I actually need more skills to deduce what you can't tell me, because that is an important part of examination as well. But I don't have access to that. But also my liability probably increases because I'm more likely to miss something virtually. So is it fair that the fee should be cut for that? I don't know. But what is clear is that the biggest win is that it will enable those who are in rural areas where there are fewer health facilities to be able to be seen by more practitioners.
And then a question from, and I hope I pronounce this correctly, Mkululi. Should the price increases by schemes have a regulated limit? I've just seen a scheme announce a 6% increase. So your thoughts on that, Dr. Bhengu?
Yeah, I think the point right now is that there really is no regulation on that front. But part of the recommendations that the Health Marketing Inquiry put out go exactly there. It's hard to sort of say right now, as things stand, should it be regulated? But it's the whole point that there has to be more. What you want is for schemes to justify the increases. And some of the responses that they've given us, for example, were that, well, they have to meet the 25% reserve before they can think of any surplus. So that was one point that was made, that we actually could be seeing lower premiums if we didn't have to hold 25% in reserve. And that point being made more by the larger schemes, because they're saying we are self-insurers really, because the probability of the scheme getting wiped out by a few people getting very sick is much less, the bigger the size of the scheme. So the point is that there certainly needs to be an obligation placed on the scheme to justify. And what I've been saying today is that corporate South Africa is one entity that's not holding schemes to account on that front. Clearly, there is a role for the regulator as well, but I was just bringing in a new angle here.
Lunga with that wants to know if medical schemes are non-profit, who is the money going to? And I think you've covered that slightly in some of the answers now. And further goes on to say insolvent schemes do not help anyone. So surely schemes are better placed to negotiate costs or drive innovation.
Yeah, the Medical Schemes Act certainly requires, or medical schemes are not-for-profit entities, but administrators are for-profit entities. What we found in the inquiry, we wondered if there's no one thing that explains everything, but we wondered if this contributes to the escalating costs. Lastly, from the reason that you have, on the one hand, administrators who are service providers who have got profit incentives. That on its own is not an issue. But the question is, if their clients have no such incentives, what does it mean? Are they as committed to act on behalf of the member of the scheme? And that led us to recommend that people must be, there must be sort of governance issues that need to be tightened, whether it's the trustees or the CEOs or principal officers. They must also be, there must be a pay for performance type of arrangement to make sure that everything is aligned to the members' interest.
So the last two questions we've got in the Q&A box is some clarity on some of the items you mentioned during the slide presentation. The first one from Zenschler around item 6 under the 9 trends that will shape that slide. She wanted a bit more clarity around what we meant by employers will be sued for the vaccine. Will it be sued over COVID vaccine requirements, or is it that if employers do not provide it and they have the capabilities to do it, they may be sued? Could you provide some clarity on that, Dr. Bhengu?
Yeah, no, the point is that this is in line with the recommendation, or sorry, the anticipation that more employers will purchase vaccines. And the fear is that once they buy those vaccines, they will then expect everybody to take them. And if you don't take your vaccine, then there might be consequences for your deployment at work, and does that count against you? And maybe that's where they fear that litigation will come in, because then employers will then feel that they have the right now to dictate what passes as infringement of your rights. This is a question that frequently comes up in the context of these vaccine passports, as to where that will take us, as to whether that's acceptable, whether that's legal. So that issue on that point 6 is linked to that to what extent will that vaccine passport be the reason why your rights in some way are infringed.
Thank you. And then our last question from Hosem Menam, I hope I said that right, is thanks, firstly, Dr. Bhengu, thank you for this great insight into the healthcare sector. However, your slide on the share of the health market share did not address the laboratory sector, given their relevance in the current discourse of COVID management, ability to create more jobs, and the dominance of the big 3, Lancet, Empath, and Pathcare. So what's your comments around that in the laboratory sector?
Yeah, the laboratories, remember, they will have fallen under specialists in the sense that you are looking at it from companies, but the sector looks at it from medical practitioners and under specialists by and large. So their fees come in there. And the YASO, certainly Lancet, Empath are 2 of the largest pathology groups. But yeah, I know they are accounted for under medical practitioner, specialists in particular.
Thank you. Well, that brings us to the close of our session this morning. Thank you very much, Dr. Bhengu, for joining us and giving us your insights around the healthcare sector in SA and how corporate SA can assist and be more involved in this, as well as the trends and things to look forward to in terms of the future. From the comments in the group chat, I can see our members and attendees enjoyed the session very much. So thank you. And thank you for all our members joining in this morning. Dr. Bhengu's details are on your screen here. Oh, what happened there? Let's see. Dr. Bhengu's details is on your screen, so you can contact him via those details. We will share the slides as well as the webinar recording with all attendees as well on our YouTube channel and website. So we look forward to seeing you all again next week. Otherwise, have a great week. Goodbye.
Thank you very much.